sir and good morning friends. We are going to present a case on respiratory system. Patient name is Mr. Sita, a 50 years old female who is occupation by farmer, residence from Tirunelveli, belonging to lower socioeconomic scale. Came with chief complaints for cough and expectoration for 1 week and breathlessness for 1 week. Patient was apparently normal 1 week back, then which she developed a cough which was acute in onset, increasing in nature, associated with sputum production, which is moderate in amount, mucoid in consistency, white in color, not blood stained, non pore swelling. No diarrheal variation and postural variation, no aggravating and relieving factors. Along with that, she had breathlessness for 1 week, which was incident in onset, progressive in nature, MMRC grade 2 to grade 3, aggravated on exertion and relieved on rest. Not associated with orthopnea and paroxysmal nocturnal dyspnea. No history of fever, no history of night sweats, evening rise of temperature, no history of hemoptysis, no history of loss of weight and appetite, no history of chest pain, no history of palpitation and syncope. Past history, she is diagnosed to have pulmonary tuberculosis for 1 year back and treated with ATT for 6 months and stopped according to doctor's order. Not a known case of diabetes mellitus, systemic hypertension, not a known case of COPD, bronchial asthma, no history of drowning, anesthesia, dental extraction, head injury.
Menstrual and obstetric history. Menarche at 14 years, married at the age of 20 years, 2 female children. Last childbirth at 24 years of age, not attained menopause. Family history, no similar complaints in the family. Personal history, mixed diet, appetite normal, sleep pattern undisturbed, bowel and bladder habits normal, not a smoker, not a non-alcoholic. Summary, a 50 years old female came with complaints of cough with expectoration, breathlessness for 1 week, MMRC grade 3. She was diagnosed with pulmonary tuberculosis 1 year back and treated with ATT for 6 months and stopped with after doctor advice. Problem system involved is respiratory system.
Respiratory system involved?
Because of cough with expectoration and breathlessness.
So this 50-year-old female had cough with expectoration and breathlessness for 1 week duration. And you mentioned it is MMRC grade 3. I don't know what is MMRC 3. What is MMRC 3?
So modified medical research council.
So what is
It is walking breathlessness and walking 100 meter.
100 meters.
100 yards.
she feels breathless after walking?
100 meters.
100 meters.
Okay, that's why you mentioned. What is actually MMRC grade 3 as this patient? This patient has grade 3.
Yes.
So what is actually grade 3? A patient feeling breathlessness after walking.
100 yards.
This lady has that.
Yes.
You cannot walk even 100 meters. So, the duration is 1 week.
Yes, sir.
Okay. And he had IBT in the past. So, from the history, what is your possibility?
Sir, it can be pulmonary reactivation of TB.
When she had IBT 1 year back,
Yes.
6 months.
Sir,
She had tuberculosis 1 year back.
1 year back and
She
she
took
took medicine.
treatment for 6 months. So, and there is a 6 months gap between the present symptom and the completion of IBT. Is it so?
Yes.
Was she normal in that period?
She was normal.
She was apparently normal in that period. Now there is one big history of course with expectation of the business of MMRC. So what are the possibilities? There is a 50-year-old lady had IBTB 1 year back, after 6 months back, was normal otherwise, doing all activities. Now what we consider why you suspect tuberculosis? Can you justify? You only told me that I am suspecting tuberculosis, no reactivation. You explain why.
We choose because he had past history.
That's what I am asking. When will you suspect tuberculosis in India in a patient?
From the history.
From the history.
What will you say? To say it is given in SPF, not here. This
Then the SPM book says when you will suspect
Cough.
Every PHC you go, there will be a ward.
board.
Cough.
With expectoration.
How long? That is important.
More than 2.
More than 2. Initially it was different, now it has been modified.
2 weeks.
SPM book says
Fever of unknown origin.
how long?
More than 2 weeks. 2 to 3 weeks.
Now you got the 2 to 3, 4 weeks left. What the book says? What is it?
2 weeks. 2 weeks, sir.
Good. Then what else? What is cough expert? What other thing? We have more components.
Evening and exam temperature, fever.
Loss of weight and appetite.
Significant loss of
Anyway, you have to suspect tuberculosis. That suspect word is now not there. No? So what is a new word for thinking tuberculosis as the differential diagnosis?
Probably.
No. Whenever there is a board that when there is cough of more than 2 weeks duration, with or without fever of more than 2 weeks duration, you investigate for tuberculosis. Previously, when we were students, the word was suspecting tuberculosis. Now the word is presumptive diagnosis of tuberculosis. We have a provisional diagnosis of tuberculosis and should be investigated. But unfortunately for us, this study has only 1 week. Is the thinking of a tuberculosis as a first diagnosis justified or not? My next question is, when this 2 weeks criteria is not applicable, when there is a patient with cough, expectoration and or fever, loss of appetite, loss of weight, you have to have a clinical suspicion of tuberculosis. I won't call it as a suspect, clinical suspicion or presumptive diagnosis. This 2 weeks business is not applicable when there is a close contact with a sputum positive patient. Even 1 day history, suppose the wife is suffering from positive, after coughing for 1 week, it's enough to suspect tuberculosis, number 1. Number 2.
Past history.
Okay, previous history. Okay, that's not very current, but immunocompromised patients, including diabetes, HIV, patients on steroids. Number 3. Anyone sitting in this hall is brought for tuberculosis. We help people, health workers. 2 weeks is not required. Even 5 days you have to suspect. Okay. Then any patient have extrapulmonary tuberculosis, like a TB lymph node or a TB meningitis. Even 1 week history is enough to suspect a pulmonary tuberculosis. It's so. So normally you do suspect tuberculosis when there is more than 2 weeks of cough and or fever. But that 1-2 weeks is not applicable when he is immunocompromised, he has extrapulmonary tuberculosis, he has a close contact with a sputum positive patient, or our health workers. This 2 weeks is not applicable. Now with that knowledge, you interpret the history. Let's say 50-year-old lady coming with 1 week of cough with expectoration and she had an anti-TB history in the past. So what is the possibility? First possibility, thinking reactivation of tuberculosis, we agree. But that won't be the first possibility. That can't be the first possibility.
due to immunocompromise.
We don't know. We know the history only, sir. So a lady 50-year-old coughing and expectation for 1 week. What are the different diagnoses? Sir, I told you in the morning.
Pneumonia.
There could be lower respiratory infection. There could be pneumonia. Now, what you are thinking of tuberculosis as the first possibility and not against tuberculosis. So you think patient coming with 1 week history of cough. Just think of a respiratory infection, lower respiratory, upper respiratory, or a pneumonia. So the duration is only 1 week, no? You have to think of the condition which Sarah has taught in the morning, which can present as cough. Pneumothorax will not present like this. No? That's actually an acute condition. So the duration is important. Symptom is also important in making your differential. So we will make the possibility of a respiratory infection, lower respiratory, it could be a pneumonia. It could be one of the possibilities could be a reactivation tuberculosis that has to come in the lower down in the list. Are you with me? Okay.
So one more thing is you have to say when there is expectoration, you should say there is a parenchymal involvement.
Yes.
It's not air passage or not. Air passage will not have, they will have small particles. So now you have to suspect parenchymal involvement.
On general examination, patient appears comfortable at rest, conscious, oriented to time, place, and person, moderately built and poorly nourished, clubbing grade 3%, no pallor, ictus, cyanosis, lymphadenopathy, and edema, no external markers of TB present. Vitals, pulse rate 76 beats per minute, rhythm regular, volume normal, character no specific character, no radiofemoral delay, no vessel thickening, felt equally in all territories. BP 110 by 70 mm of Hg, measured in right upper limb in sitting position, respiratory rate 18 beats per minute, rhythm regular, type thoracoabdominal, temperature 98.6 degrees. Coming to examination of respiratory system, on inspection, upper respiratory tract nasal mucosa is normal, no nasal septal deviation, no nasal polyps, no sinus tenderness, no nasal discharge or post-nasal drip. Oral cavity, good oral hygiene, oral mucosa, tongue, teeth, gums are normal, no dental caries, no halitosis. Examination of chest wall asymmetrical, spine deformity, scoliosis with convexity towards left side, trachea divided towards right side, tidal sign seen in right side, apical impulse not visible, drooping of shoulder on right side, supraclavicular and infraclavicular aloneness on right side, accessory muscles of respiration not in use, no dilated veins, scar, sinus or tapping mark. Chest wall movements. It is normal on left side and it is diminished on right side.
All areas.
All areas, apical.
All areas on the right side
Diminished.
diminished. You have to specify that also, no? Don't just say right side diminished. You can specify that area when you present in the examination.
On palpation, on chest wall there is no warmth and tenderness, and trachea is deviated to right side, and apical impulse is seen in the left.
Patient is confirmed. Palpation.
Apical impulse in the left intercostal space, which is half inch medial to the midclavicular line, and movements there is, on left side it is the normal movements, and on the right side on all areas it is decreased. On measurement, on inspiration the 82 cm, on expiration 79 cm. The total chest expansion is 3 cm. And a hemithorax measurement, on the right side on inspiration 40 cm, on expiration 39 cm. There is a chest expansion of 1 cm. And on left side the inspiration is 42 cm, on expiration 40 cm, and there is a chest expansion of 2 cm. And the movement diminished on the right side. No tactile perimeters and friction perimeters. Vocal perimeters appears normal on the left side, and on right side it is increased on the supraclavicular, infraclavicular, axillary, suprascapular and upper interscapular areas, and other areas look normal. On percussion, the clavicle is resonant, and on the left side all areas are resonant, and on the right side the supraclavicular, infraclavicular, axillary, suprascapular and interscapular areas are impaired, and other areas are resonant. And on auscultation, normal vesicular breath sounds are heard on the left side, and on the right side on the supraclavicular, infraclavicular, axillary and suprascapular areas and interscapular areas, just cavernous breath sounds are here. Other areas vesicular breath sounds are here. Vocal resonance, it is appear normal in the left side, and it is increased on the right supraclavicular, infraclavicular, axillary, suprascapular and interscapular areas. Fine freckles are seen in the right infraclavicular areas, and there is presence of post tissue section. Other system examination, cardiovascular examination.
Anything possible in the other systems? No.
No.
So we will concentrate on the respiratory system. Sir, can you bring that patient? Okay, can you just tell the positive findings? Oh, it's written there. Okay.
First, on Gestural movements are reduced on the right. There's presence of grade 3 clubbing, and the trachea is deviated to right side, and a drooping of shoulders on the right side, and the supraclavicular and infraclavicular hormones are present on the right side, and the gestural movements are reduced on the right side, and the vocal perimeters is increased on the right side.
Chest movements reduced on the right side.
Uh,
Up to that level, what is your inference? So there is a patient who has grade 3 clubbing. So as we thought in the history, it's not an acute problem. No? An acute pneumonia or a respiratory infection should not produce a clubbing. So clinical examination, we are thinking of a different problem for that patient. No? For that patient. So findings are grade 3 clubbing, trachea deviated to the right side, drooping a shoulder present on the right side, supraclavicular, infraclavicular following on the right side.
Any volume loss?
Obviously, there is a volume loss on the
Right side.
Right side.
right side. No, there is a volume loss. What are the signs of volume loss in this particular patient? Not this patient.
So the presence of hollow mass, drooping of shoulder,
Supraclavicular, infraclavicular,
hollow
following.
mass and drooping of shoulders.
Ah.
Trachea deviation towards the right side.
Okay.
Can be scoliosis.
Drooping a shoulder on the right side. Why we said the right side is abnormal? Because all other findings on the left sides are normal. So we have to think that the right side is pathological or abnormal, and the pathology is a volume reduction in the lung, which has pulled the trachea to the same side and caused drooping of shoulder. Okay. So the reason for trachea shift to the same side is what?
Volume loss.
Volume loss is pulling. Why that drooping happened?
No.
It's not collapse. The lung is fibrous.
Volume loss.
When there is a volume loss due to fibrosis and all, the drooping of shoulder happens after a period of 3 to 6 months. Now, usually, what is it due to?
The muscle.
It is due to the
Muscle wasting.
disuse, atrophy or wasting of the paraspinal muscles on that corresponding side. Trachea is being pulled just because of the volume loss. Like the balloon, the lung is streaming and trachea is coming at the same time. But drooping occurs due to the muscle weakness, muscle atrophy. That is why the drooping will develop after 3 to 6 months of the pathology, not immediately. Okay. So that level we can assume or presume that there is a right sided lung
Volume
volume
loss.
loss. Since the trachea shifted to the right side, we have one more information that the right upper lobe is reduced in volume. Okay, upper lobe is reduced. Drooping can develop due to upper lobe, middle lobe or lower lobe or entire lung. It's not related to the lobe. So always remember, volume loss has signs in this patient like trachea shift, following, drooping. Trachea shift indicate upper lobe volume loss. Drooping may be due to that, we don't know. We have to see the other findings also. Go ahead.
Then you link it to the intercostal space, right? Palpation. Is there any narrowing of the intercostal space? One more thing, additional thing we have to look into. Is there any intercostal narrowing?
Did you look at? So this is a leading question Sir is asking. What is the importance? You can look, you can later on look for that. And what is the
fibrosis,
crowding
there is
of
crowding
ribs.
of ribs.
suppose that patient has crowding of ribs on the right side as an additional finding. In addition to these findings, what is the clinical significance?
In a long-standing volume loss.
Lower lobe volume.
Long-standing fibrosis case.
Long-standing fibrosis, how does it produce crowding of ribs? See, this grouping of shoulder trachea is due to the volume of the lung. Is it so?
Yes.
And it should not affect or may not affect the chest wall cavity. So gradually, as time goes on, there can be the crowding of ribs also. The space will be reduced. Why? It more indicate the pleural fibrosis, associated with pleural fibrosis. So when there is associated crowding of ribs, that's a clue that the pleura is also get fibrosed. So that finding is also important in patients to know this. Okay. Continue.
Vocal perimeters increased on the right side, and impaired notice inhaled on percussion on the right side, and low pitched bronchial breath sounds, which is cavernous sounds on the right side, and vocal resonance increased on the right side. Fine crepitations here on the right infraclavicular area and post-tissue suction surface.
So you break at the point of vocal resonance increase on the right side. So we have additional findings of vocal fremitus and resonance increase on the supraclavicular, infraclavicular, axillary region and suprascapular region, upper part. Okay. You have a cavernous breathing also. What is cavernous breathing? Anyone? It's a low pitch bronchial breathing. What is a bronchial breathing? Anyone? By definition. It's a usual question for undergraduates. What is bronchial breathing? High pitch is tubular bronchial. You have a low pitch bronchial breathing here. You only said it's a low pitch. Then we don't go into the pitch.
Normal inspiration and expiration.
In normal human being, inspiration and expiration, which one is passive?
Sir, inspiration is like
Is there any
3
gap?
to 3 stone ratio. There will be no gaps.
Okay, what is the rate? 3 is what? Okay. Then is there any gap between that? Your inspiration is followed by expiration or there is a gap?
No gap.
No gap. In bronchial breathing? There is bronchial breathing. Expiration is well had or equally had with a gap in between. That is bronchial breathing. It can be low pitch or high pitch. This particular patient you have a low pitch bronchial breathing which is called cavernous breathing. So what is cavernous breathing? A low pitch bronchial breathing. What is the significance?
Cavity in cavity.
Low pitch bronchial breathing is a pathognomonic sign indicating a cavity inside. Inside. To get a cavernous breathing in a cavity, what are the criteria the cavity has to satisfy? At least one. It has to communicate with the bronchus. So this lady has a cavity in the right upper lobe which is connected to the bronchus. That is the information. And you come in with the other findings. That area you are getting BF and BR high. Increased. So what does that tell you?
Can be fibrosis.
Can be.
Fibrosis.
So around the cavity, in and around the volume, the neighboring area of the cavity, there is the
Fibrosis.
lung which is changed into a solid type structure. Okay. What are the conditions where you can get increased vocal resonance that you have got in this patient?
Consolidation.
Consolidation,
Fibrosis.
fibrosis. Cavity will produce a cavernous breathing. Cavity per se will not increase the vocal resonance from it. Mastication, no? So when the lung, which is a soft tissue, say spongy like this, when it changes to a solid structure, which happens in consolidation, in fibrosis, in mastication, you will get a increased vocal resonance. This particular patient, there is a volume loss. So we are not thinking in terms of a consolidation. Is it so? So we combine a pathology which can produce volume loss on the right upper lobe area, which is producing increase in vocal resonance with a cavernous breathing. So what is the pathology?
Fibrosis.
So that's the logical thing. You have to think of a pathology where the lung is changing into a solid structure, causing volume loss, and there is a bronchial breathing inside which is cavernous. So what is your diagnosis?
Fibrocavitary lesion.
Fibrocavitary lesion is possible. So to confirm that, we can have the lower findings also. What is that?
Minute repetitions had on a right infarct.
Clinical significance of that repetitions. Just think whether fibrocavitary lung disease is your diagnosis. No. Where? Right upper lobe.
Right up.
You just think the above two, there are two pathology, fibrosis and cavity. Which one will produce fine repetitions?
Cavities.
Case of TB, the upper lobe repetitions are
Which condition produce fine repetitions with the lung? One is fibrosis.
Consolidation.
Number two, when the consolidation of pneumonia resolved. So whenever you get a patient, person with a cough with explanation, you put a stethoscope here to find out repetitions. So an early lower respiratory infection or a resolving pneumonia or a fibrosis, you get 5 repetitions. So what is your diagnosis previously? Fibrocavitary. So can you explain this repetition there? So that also give an incentive or a clue or confirmation to your diagnosis. Okay. Now there is one more sign. That is
Post-occlusive suction person.
section. What does it indicate?
So it indicates it, cavity is superficial, it is collapsible, thin wall.
Okay. Superficial,
Collapsible,
collapsible,
thin wall.
thin wall. Two are correct, one is wrong. The cavity need not be collapsible to have a post-occlusive section. You forget about that. Anyway, that finally confirmed that your cavity diagnosis is also correct. So, can you come? So, combining all your findings, what is your diagnosis?
Sir, I have fibrocavitary lesion seen on the upper lobe, right upper lobe. Etiology can be pulmonary tuberculosis, previous pulmonary tuberculosis.
Then why the patient doesn't have 1 week of cough? So you are diagnosed fibrocavitary, which is due to all tuberculosis. Why this 1 week of cough, man?
So it can be reactivation also.
Come on. It is the undergraduate level.
Secondary infection, bacterial infection.
There is a cavity. Can definitely get a secondary infection. So what is your final diagnosis? So this is given as a case. With the findings, your diagnosis is fibrocavitary right upper lobe. For that, the etiology is
Tuberculosis.
what is our present problem?
Superimposed with the secondary
Since
infection.
secondary infection, you need to treat. No, that's the final diagnosis. So what is your final diagnosis?
Right upper lobe fibrosis with cavity formation. Probable etiology is tuberculosis, superimposed with the secondary bacterial infection.
That's it. Full mark. So, auscultation is the sorry. Can you just do the percussion on the right infraclavicular region? Sorry. Yes. Do the percussion in the right position. That happens. You always ask the patient, you never ever do the percussion in the right position. Why? When he lie down, the posterior part of the chest is completely prevented by movements and the sounds created by the spinal cord by the blood which is in front of the posterior side. That's why never do the percussion in the right position. Always let the patient sit comfortably. Tell the patient that I am going to percuss. Very, very important. Make it an art. Whenever you do the patient, just tell him so language that without hurting you, I am just going to percuss. So you do the percussion in the right infraclavicular region as a scientific way. Patient is sitting. We told the patient we are going to percuss. Okay.
As flexor and we should percuss.
How will you percuss supraclavicular area? Supraclavicular area.
Supraclavicular area. So
We have percuss starting from above. Below the clavicle.
you ask for the infraclavicular. That's
Alright, sorry.
before just says for this very well taken. Before that, you are actually using this middle finger and this finger. Huh? What is this finger called? Flexing midline flexor. So steps important are you have to keep your what is this finger? Pressing middle finger in the intercostal space which you are percussing. Okay. So this is the fleximeter finger which is the middle finger for your left hand. Keep it in the intercostal space and your index finger and ring finger has to be away from the chest wall. Otherwise, if you do like this, what will happen? You are preventing this intercostal space and this intercostal space, preventing from movements, normal movements. Your interest is to look into the resonance of this space. So this fingers has to be away, and this is the flexor finger which has to move from the wrist like this, just to generate the sound. So things important are sitting position or standing position, preferably sitting. You tell the patient, use this finger, middle finger in the inner zone. These two fingers has to be away, and do the percussion without hurting the patient. Sufficient to generate a sound. So that is the method of percussion. The things which can get in clinical examination are you can have normal resonance, you can have a impaired resonance, you can have a dull tone. Some books say you can get a stony dull tone also. Stony dull tone also. As sir mentioned in the morning, what is a normal resonance? as you focus over your abdomen. Sorry, tympanic or a normal resonance or tympanic one. And when you put over your muscle, that is impaired. When over a bone, it is tonic. Or a dull. When you appreciate pain in the finger, percussive finger, it's a stonic dryness. But now books are not very concentrated on the stonic dryness because it's a subjective feeling. Some may get pain, some may not get pain. Okay. So now first question, how will you percuss the supraclavicular fossa, which is the first thing you have to do when you do the percussion. Do it.
You should go behind the patient and should
So percussion of the supraclavicular area. What is this area called? Chronic isthmus. Oh, how will you do the percussion? She is telling there are two methods. It's correct. There are two methods.
3 fingers and then you can go from medial to lateral, sir. Or you can use single finger and
Medial to lateral means here or here. Here.
here. Or you can use a single finger and then you can go from this.
Can you do it from the front? This is chronic isthmus or supraclavicular fossa. You said you will stand on the back and keep the 3 fingers and percuss from the medial to lateral. That's correct. Or you can do in the anterior area also. You can stand in the front, you use it and make the finger parallel to the clavicle and you can just do the percussion. That's also possible. But I don't know for undergraduates which is the method taught, I don't know. So we have to go with the consensus because otherwise.
One doubt is that. One doubt is that whether the candidate, whether the student should percuss the supraclavicular area and the chronic isthmus. Supraclavicular area you are percussing anteriorly, and chronic isthmus you are percussing posteriorly. Any difference?
Actually, both the supraclavicular region and chronic isthmus indicate the apex of lung. Apex of lung is vulnerable for infection, fibrous, marriages, etc. So that's why we have specifically termed that area as a chronic isthmus where you have to percuss from the back. Normal percussion from the anterior side and just doing the supraclavicular is enough. Anything abnormal, you can just concentrate on the chronic isthmus area from back.
Another doubt is when you are percussing the chronic isthmus, last smart program, actually whether you can keep all the 3 fingers together or 1 finger alone. That was a doubt.
The correct consent, there also I am going with the consents. Books may vary, teachers may vary. The consent is use the middle finger alone. The examination, as I said, one examiner from Kerala may come, may say that you are not using the 3 fingers. See, my consents in our institution taught us, even the SMART program taught us like that. You can only reproduce what you have been taught. So, that you can say definitely no. There she is consensus for some of the findings which are confusing. Students are always bringing the points which are actually confusing in the clinical examination. So even Vivekanandan Medical, there is a book on clinical examination, a consensus book.
That showed 3 fingers together.
That is developed only because examiners from Andhra Pradesh and Kannada are coming and arguing with the examiners of Trivandrum that this is not the method. The student is actually being penalized. What they did, now the students are saying, we have a consensus book in our department. We are taught like that. Then the exam will be decided. So these 2 methods, all the clinical methods are just to get a positive finding or no, to make a diagnosis. If suppose the supraclavicular fossa is normally resonant, you can stop it there. If it is impaired, then you concentrate like a chronic isthmus and make more findings. No, that is it.
Anteriorly where the bracing position is important. Bracing position, anteriorly percussion. Is it important?
Like
Suppose you are doing like this or you want to do a bracing position.
this is actually not.
Not.
When you do on the back, actually, this is.
What is the significance? You said chronic isthmus is obliterated. Any other finding you can identify in this supraclavicular percussion? If it is hyperinflated emphysema, you will have hyperosmosis. That you should.
So any other finding you want to demonstrate in the percussion? So the normal percussion, the normal areas you have to repeat every areas. No? Always compare with the normal side. Say that it is impaired, dull, resonant, tympanic or hypersonant or even dullness. That is supraclavicular. can you do the direct percussion? Are you being practice the direct percussion? I will do direct percussion. Next also, you do it. Can you just demonstrate how you do the direct percussion of the clavicle? Again, the position of the patient is sitting. So this is a total clavicle. This is medial one-third. This is lateral two-third. And you are percussing here. Why? Each one has a scientific explanation. Because this is the point where your apex leg is close to. That's why you are selecting this space. Okay. Then always come the opposite. Okay. I don't know whether the teaching is like that or not. So there is some books say that always there can be a loose fold of skin over the clavicle. So you stretch. So the corrective method is patient is sitting with the middle finger of the left hand. You can stretch like this, or with the thumb and next finger you can stretch like this. And at the junction of the medial one-third and lateral two-third, you just do the percussion compared with the opposite. Some patients, this loose fold of skin can interfere with your percussion, but that not compulsory. But if you are asked to demonstrate in the exam, better to do like this. Okay. Stretch the skin and do the percussion, then you will get a correct also. So direct percussion is over, indirect percussion is over, and supraclavicular chronic isthmus is over. Anything in the percussion? Tidal percussion. That also will demonstrate. How will you do the tidal percussion?
First we should
Can you do it in the lie down position? You can do it because you are looking for the diaphragmatic movements and liver respiration. But better method is in the sitting position.
we should focus from the second intercostal space.
So start percussion. If it is resonant, you can start the percussion from the second space. Okay.
And we should go up to fifth intercostal space to feel any for liver dullness.
You need not do the 15 intercostal space. Wherever there is a dullness.
Wherever there is dullness. And then we should go 2 space down and we should focus from below to up.
She will correct. You are correct. Don't become test. This should not happen next time. Be confident. We are correct. You did it correctly. And there is an example. This is only demonstration. For example, these small things are actually not good. Don't get this complicated. The examiner may shout, he may smile. You can only reproduce what you have been taught. That's why we are doing this program. How do you do it?
Sir, after percussing, when we get a dull sound, we have to ask the patient to inspire, and then we'll have to see if it is changed into resonant. If it is changed into resonant, then the pathology, we can classify it as supradiaphragmatic hypertrophy.
So, as your idea says, this diaphragm percussion is being done to look for position of the diaphragm, and the pathology is supradiaphragmatic or infradiaphragmatic. Okay. So, you select 3 areas: midclavicular, mid-axillary, and posterior scapular line. Same method. Okay. In the mid-clavicular line, you start percussing to the second intercostal space if it is resonant. But our patient, the infraclavicular region was actually dull. Supraclavicular. That patient also you can start from the second space. And the third space is resonant. Fourth is also resonant. Fifth usually has to be dull because the liver is coming there. So the diaphragm is somewhere there. So you percuss, it is resonant, and it is done. Okay? Then you keep your left finger, middle finger there itself. Don't take it. Ask the patient to take a deep breath and hold it. Then do the percussion. Normal person, that space which was dull earlier will be resonant, and one space below also has to be resonant. So the finger where your dullness is good because of the liver will move down, so that space and the below space will be resonant to say tidal percussion, normal or positive. Suppose what will happen? You will get a dullness even after deep inspiration. So the tidal percussion is negative. Okay. So what is the information? Can be plural. Can be pyramidal plural. So in situation where there is fibrous lung or pleural effusion, you may not be able to do this one because already it is dull. You cannot differentiate. So what you have to say, the tidal correction I cannot appreciate because the dullness is merging with the already existing dullness. Got it? So that is the way you have to do the. So that is regarding the tidal pressure. Same procedure between the mid-axillary and posterior scapular. Normally 5, 7 and 9. In emphysema what will happen? That will go down because of the lung being hyperinflated. It will be 6, 8, 10 in most of the cases. 5, 7, 9 is normal hyperinflation, and sometimes what will happen? It will merge with the other opacity which is present in the lung disease. So I think percussion, these are the things. The cardiac bottom,
On the left side,
props.
how will you practice drop size? What is the surface anatomy? What is the boundaries?
Normally the top size will be tympanic. Okay. Pleural effusion.
Left lobe of your
Enlargement, hepatomegaly, left lobe. Even stomach pathology, carcinoma, all these have a dull or a top size will be obliterated. We call it as it is obliterated. Normally it will be tympanic or sonnet. The simple method to find out the splenic dullness in the mid-axillary line. You percuss and you get a dullness like this in the spleen. Just above the spleen you have the diaphragm. But example will ask you the boundaries of.
So usually we say 6 rib above, laterally be mid-axillary, below by the costal. That is easy thing. Even in hands.
So that is
Physiologically, full stomach may get out. Drops with.
So I think then in the hard bottom, that actually serious examination they will just percussion. Now the last part, which is this is the auscultation. But sir want to demonstrate the posterior percussion. Suppose you are asked to percuss the right side on the back. How will you do? ഈ അപ്പസൻ മലയാളം So she is going to demonstrate the clinical method of percussing the posterior part of chest or thorax. So this is important. The patient has to keep the arms on the opposite shoulder so that you get a broad space of the scapula. Always remember the scapula is not used for percussion. We are actually leaving it. Okay. That okay. And compare with the opposite side. Can you just demonstrate the percussion of the suprascapular region? Okay, so there, then your finger has to be parallel to the scapula. Here, even you can do horizontal also, but I think you need vertical, not like a perpendicular.
One consensus for that.
That is something.
The suprascapular, whether you are placing like vertically or horizontally, one doubt. Vertically or super. And here what last smart program, what one of the physicians have demonstrated, in the scapular area, not like this, the rib space is like this, we have to do in the rib spaces like this. And infrascapular same. Your comments.
So book says, McLeod says like that only. But we can, according to sir, we can even use this finger like this also. So McLeod says, according to the oblique changes, we have to practice.
Only Professor, suppose the exam, who is coming, that's important.
That is important. Internal examiner has to substantiate, that is more important.
Actually, the doubt, to my opinion, I think that's almost a consensus. The suprascapular area, the middle finger has to be parallel to the scapula, like this. 1, 2, 3, that is enough. These ribs are going like this. The general rule is to keep the finger in the intercostal space. So that is accepted. But for this area, actually, majority of the area on the back is suppressed in the lower lobes. Except the suprascapular, upper interscapular, all these areas are represented by the lower lobes. So even if you do the percussion, so you palpate the intercostal space and find out like this. This is one method. Even this area is all represented in the lower lobe. If I get a dullness here or here, the pathology is same in the lower lobe. No difference. So if I do like this, I am getting the same findings. But anteriorly, supraclavicular represents the upper lobe, mammary represents middle lobe, left side it is lingular. So there is a difference. This entire area is to the lower lobes. So there are two methods are accepted. So consensus, supraclavicular, the finger has to be parallel to the clavicle. This area either can be parallel in the intercostal space like this, or even this is also permitted. Because all these areas are permitted to the lower lobe. Both are permitted. Ideal method, suppose like students want to demonstrate in the next exam, you can use the first thing which Sir has done. You can use in the intercostal space. That was the consensus last smart program.
Last smart program, no, the students have performed like this, vertically. But sir has told it should not be there, it should be in the intercostal.
Actually, vertical also is permitted. In the consensus book, the method is in the scapular area, your finger has to be in the intercostal space. In bracket, vertical finger method is also accepted. Both are accepted. So that is the percussion on the back. Now I think that complete the percussion. Now auscultation and
Sir, one more. Sir, one more. Jagged percussion on the left side.
same. How do you do the tidal percussion on the left side? Can you demonstrate? Don't fall. Right side we demonstrate, no? How do you do? The tidal percussion always done just for finding out the level of diaphragm. Right side the diaphragm is above the liver. Left side the diaphragm is above the. Since liver is on the right side, it's easy to percuss on because it's a solid structure. Unfortunately, lung is resonant, our fundus is also resonant. It will confuse you. The only solid structure on the left side is spleen. So first you can percuss the mid-axillary line and find out where the splenic tendency is coming. And the second method in the mid-clavicular line also you can percuss out and that will be corresponding. Same, simple. And Prof is actually centered the lower postal part like this.
My doubt is whether it should be done in the mid-scapular line. Left side, whether it can be done in the mid-scapular, because liver is there. Mid-scapular. Mid-scapular line. Posteriorly in the seventh space. Then you percuss.
Mid-scapular, I don't know. I am not aware of that method.
Because right side liver
We
is
can
there.
do that, but only thing is posteriorly muscle are thick, so we find it very difficult to appreciate. That is why we don't prefer posterior as percussion.
You are telling mid-axillary.
Splenic tendency is actually, it is easy to just behind the mid-axillary line. That is the best method to find out. Any comment?
Usually we don't do left side
Suppose the examiner is asking very specifically how to do the tidal percussion on there, not usually required. What is our traditional? Not normal cases not required. Suppose there is a unilateral left-sided diaphragmatic pathology or situation like that. The examiner insists that how will you do the teleportation on that side? Just to find out the diaphragm, the splenic dullness we can find out. That is already method. In usual examination, left-sided teleportation is not required. That's what, it's a valid point. But unless the examiner is asking for a left-sided pathology, then you can just say that on the mid-axillary or posterior axillary line, just percuss out and find out the liver splenic dullness. Thanks. Auscultation, anything to be demonstrated? Preferably auscultation also has to be done in the sitting position. Auscultate to supraclavicular, infraclavicular, mammary, axillary, infraaxillary, suprascapular, interscapular, infrascapular region. Look for the breath sounds or the air entry and compare whether the air entry or the sounds is normal and equal on both sides. Number 2, some examiners don't like to use the word vesicular breathing, but still I think the old examiners are continuing to use vesicular, which is a normal breathing. And if it is vesicular, okay. If it is not vesicular, you say whether it is bronchial or not. If bronchial, if you are capable, say it is high pitch or low pitch. Low pitch. Low pitch, as in our patient, is indicate a cavity. High pitch bronchial breathing is otherwise called tubular bronchial breathing, which can occur in fibrosis, consolidation, or mastication, etc. Okay. Then you look for the vocal resonance. Ask the patient to say 1, 1, 1, 1, or 1, 2, 3, or 99, and compare the both sides. The abnormality can occur. Vocal resonance can be normal and equal on both sides. It can be increased, it can be decreased, or it can be absent. When it is completely absent, there is only one diagnosis: collapse. Completely absent, only one diagnosis: collapse. It will decrease in all respiratory disease. Increase in condition which we described as consolidation, mastication, or even fibrosis. But practically, our case was having a fibrocavitary with increased vocal resonance. But then you may get cases with same findings, but vocal resonance parameters decreased. Okay, so in fibrosis cases or a fibrocavitary or a fibrosis, you can get vocal resonance and parameters decreased or increased, depending upon the patient. What condition? In our patient, there is no crowding of ribs and vocal resonance was increased. That was the finding. So diagnosis was fibrocavitary. You may get a case with same findings but decreased vocal resonance and parameters with some crowding of ribs. What does it indicate? It indicates the associated pleura is also thickened. So the fibrosis, the vocal resonance can be normal, increased or decreased depending upon the condition or status or fibrosis of the associated pleura. If pleura is okay, you will get an increased vocal resonance. If pleura is thickened, you may get there is some borderline thickening of the pleura, you may get a normal vocal resonance. Normal. Practically, to me, most of the cases you get a decreased vocal resonance because sparing the pleura and fibrosing lung alone is extremely rare because pleura is very close to that. There will be some pleural fibrosis. But in your case, it was increased, there is no confusion, there is a fibrocavitary. So that's actually complete the auscultation. Then finally you look for the added sounds. What are the added sounds you look for or adjunctive sounds you look for? Repetition, not this, okay, pleural rep. The recurrent is for cardiovascular. For lungs we have bronchi, repetition and pleural. And depending upon the nature of the bronchi, nature of the repetition, you can make different scenarios. For our case, the repetition was 5 repetition, which is correlated to fibrosis. So that patient, our diagnosis right side at fibrocavitary. What about the left leg? Normal. You may get cases with opposite leg abnormality. Suppose the right leg is fibrosed, entire leg is fibrosed. What are the things which can happen in the opposite leg? That also has to be, because we are more concentrated on the normal leg, not the diseased leg. That's already fibrosed. So the exam, you may get a right tender lung fibrosis. What are the things which can happen on the opposite lung? It can be normal. It can be normal. It can be compensatory hyperinflated because of the other lung is taking its function of the opposite lung. Compensatory hyperinflated. Sometimes what will happen if the patient is a smoker? The lung can be emphysematous. These situations can happen. Normal lung, you will get normal findings. If it is emphysematous, what are the findings? Right side is fibrosis, left side is normal findings. If it is emphysematous, what will happen? Because of the air trapping, breath sounds will be reduced. You may get bronchi also. If it is compensatory hyperinflated, what will happen? You will get very good air entry. Because it is doing extra function, you will get normal air entry. So concentrate on the opposite leg for only one finding. The air entry on the breath sounds. If it is normal. If it is hyperinflated with the normal air entry, it's compensatory hyperinflation. If it is hyperinflated with the decreased breath sounds, it's simple enough. Good. Thank you.
One doubt, not for the UVGs, for postgraduates, whether you can put a diagnosis of destroyed lung as a clinical diagnosis.
Actually, that's not accepted, but we can say in a situation where destroyed lung, I cannot find a definition. I always teach also. There's no definition, but our radiology would say when there is more than two pathology points. Suppose there is fibrosis, there is a cavity with bronchiectasis. But this patient you cannot use because there is only fibrosis cavity. There may be some work in that. So, bronchiectasis in that area, you may use the word of destroyed lung. But destroyed lung means the lung is gone. There is no working that. It is better not to use that unless you see a CT. So nicely presented.